Leo, over to you.
Thank you. It's an honour to be presenting at the Overseas Development Institute. I'm going to do a presentation on voucher schemes. And I should probably start by explaining that there's some controversy around voucher schemes. Just this week, the Guardian's blog, Development Matters, accused the World Bank of promoting user fees through voucher schemes. And I think it was Oxfam who compared the concept of providing health services, of governments providing health services through private providers to governments hiring mercenaries for defence purposes. So it has been an interesting debate at times. But just briefly, I think the interest in using the private sector for service delivery and social protection, well, to refer to Una's presentation, that key transitionary moment in the UK that saw maternal mortality plummet by so much, as well as new technology. The creation of the NHS was very much key to that transition, and that was a moment when this dichotomy between public and private was really swept away, and the government decided that it was going to take all the private healthcare providers, the private independent doctors, and get them to serve people for free by putting public money through previously private health clinics. So voucher schemes, along with other certain types of program, are all about capturing the private sector to serve the poor. Interest in voucher schemes, there's an interest in them because they remove user fees. They address the issue of distance to clinic and transport costs for women. They address issues of marginalisation and discrimination, which can be a barrier to access, and lack of information about services. And I'll touch on all of these points throughout the presentation. So I'm going to use the example of the Ugandan voucher program, which was the one the Guardian picked on, because it was one I visited in 2010. Briefly, the premise of the program is that by buying a voucher for 3,000 Ugandan shillings, which is about $1.20, a woman can go to an accredited private healthcare provider for 4 antenatal visits. She'll get transport to the facility for a safe delivery. This was a new addition to the program in 2012. She'll receive a safe delivery service no matter of complications. If the clinic she's at can't provide the service, there's a referral to a hospital, free referral with transport, and then she's also entitled to postnatal care afterwards. The program was founded in 2006, originally for STI treatment in 4 districts, and it was expanded in 2008 to include maternal health over 20 districts in western Uganda. There's 111 districts in total in Uganda, so it's a sizable proportion of the country. Between 2008 and 2011, 80,000 women used the program to receive maternal health services, and 30,000 women between 2010 and 11, women and men, used it for to treat sexually transmitted infections. And overall, there was a tripling in the uptake of STI treatment services in the region. The budget for the programme is €6.5 million, funded by both the World Bank and KfW. And some of the programme results I'm going to show were found by the Population Council, who reviewed the programme independently. So what do we mean by private sector? Well, in Uganda, 67% at the last DHS survey, 67% of healthcare seekers go to the private sector for their first port of call. And this is roughly consistent with sub-Saharan Africa as a whole, where there tends to be approximately the same amount of health infrastructure, so clinics and outlets, in the public sector as in the private sector. But we're not talking about big corporations with shareholders. We're talking about overwhelmingly the private sector for healthcare in sub-Saharan Africa, small independent clinics like this, usually run by a clinical health officer who has decided to stay in and work for the local community rather than seek a job in Kampala. The diagram of the program, we see the funding at the top, which comes from donors. There's a potential for government to play this role. Hires a voucher management agency who has a number of roles, but chiefly the voucher management agency disseminates or distributes the vouchers to voucher distributors who go to local communities and sell the vouchers to clients, and the clients can then go to accredited healthcare providers to receive the services. The healthcare provider provides those services for free at that point and receives a reimbursement from the voucher management agency. This is an image of one of the voucher distributors in Uganda, Kenneth. So why would a woman buy a voucher for $1.20 from Kenneth when Uganda abolished user fees about 10 years ago? Well, although Uganda did abolish user fees, it's quite high profile that when a woman goes to a public sector outlet, it's quite likely that she'll be charged for the gloves that are used or the medicines that are used. And these fees can amount to as much as $15 or $20. The other key point for women is that they don't really know how much it's going to cost before they get there. In the case of a complication in the pregnancy, the cost of treatment might escalate to as much as $200. The role of the voucher management agency is to accredit the private providers. The role of, so in this case this is Marie Stopes Uganda, voucher distribution, the recruitment of the community-based distributors, so people like Kenneth, the marketing of the vouchers so that women know where to get them and what they entitle them to, the continual auditing of quality. So in order to be accredited for the program, a private provider needs to be able to demonstrate that they can meet quality standards, and these standards are continually audited. The reimbursements to the providers and poverty grading. So in this case, the purpose of the program was to reach poor rural women, and so the voucher distributors were trained to ask women about their level of poverty. It's an area that Western Uganda is an area that's so poor that dollars per day income wasn't really a very useful measure, because the essentially everyone in the region earns less than $2 a day. So the poverty grading tool instead asks questions like, what's your abode made of? Is it made of mud and wood? Does it have a corrugated iron roof? So this is one of the better sort of places of accommodation. The fact that it has a corrugated iron roof puts it slightly higher in the poverty grading tool than some of the other women the program serves. Now, we don't advocate health policy by anecdote, but the first woman I spoke to in this program had quite a profound impact on me. I asked her, why she had used a voucher instead of going to a public facility, and she said that she had had a pregnancy previously and had walked 10 miles to the nearest hospital, and was told by the nurse there that she was too dirty, too unclean to be treated. So she walked 10 miles home again, and she delivered at home and lost the baby. And the same thing happened with her next 2 pregnancies. She had never been back to a hospital since. But she bought a voucher from a voucher distributor and used that to go to her local private clinic, which was a 10-minute walk away, and received a safe delivery from a provider who she knew and trusted from her local village. So do vouchers reach poor women? So this is the poorest quintile in Western Uganda. The control group that the Population Council looked at, we can see that between 2008 and 2011, in these control groups, control villages, there was very little increase in ANC, safe delivery, or postnatal care, whereas in the voucher program villages, there were some significant increases. I suppose one of the chief issues with voucher programs is what's the cost, what's the management cost of all this accreditation, voucher distribution, and regulation of private providers. It's quite high compared to a lot of other program models. So program costs can be calculated in different ways. So we've got 3 different methods here: blue, pink, and yellow, for program running costs. What's interesting, I think, is that they don't seem to increase very much with the scale of the program. So while at the start of the program, before the vouchers had really started being distributed, the running costs of the program were by far the majority. But as the voucher, the dark blue line, distribution really took off, those management costs remained the same and became a much smaller proportion of the overall program costs. Between points 2 and 3, vouchers stopped being distributed because the funding for the program had come to an end. So, how were private providers using the revenue that they got from vouchers? Over a quarter used it on medicines and supplies, and I think this is a really key point for them. One provider was explaining that if a woman comes to him unable to pay, and she's having a delivery, or she's in a state of an emergency, he'll treat her, but she might then run away without paying, and then never come back because she's afraid to come back for another service. And so from his perspective, the voucher really helped that sort of trust and confidence between health provider and client, and the fact that he knew he was going to be able to buy new medicines after providing a free service to a woman with the reimbursement was a key point. About a fifth used the revenue to increase the salaries of the staff at the clinics. About 20% bought capital equipment, and 11, 9, and 5% invested in the clinic in other ways. So Are vouchers health systems strengthening? This is the last slide, and I think that's a very big question, because the money isn't going to the public sector. If we do away with the dichotomy of public and private, as the government of Uganda has done in this case, the government of Uganda are a key partner and promote the programme to donors, then I would argue that it does. The accreditation of the service providers and the competition between the service providers, because they know that if a woman comes to them and they don't give a quality service, that woman can go to the private provider next door. That really addresses the marginalisation and discrimination point. The improved referral from private local rural clinics to the public sector was very much improved. The ability to target services at the poor, so rather than opening a clinic, and what tends to happen is that the better off members of the community will go and visit that clinic. Having a voucher that you can go and give, you can really target at the community that you want to reach. And there's various examples of successful voucher programs reaching sex workers, for example. Another key point is if the public sector is going to start utilising all this private healthcare infrastructure, it needs to start learning how to regulate and how to accredit, and voucher programs can provide an introduction to that. I suppose a final point is that from the donor perspective, they know exactly what they're getting for their money. They know, because for every voucher redeemed, we know that that's a service that was provided, and so it really addresses NGO accountability, rather than receiving a lot of money up front and then the NGO reporting on how many services provided. There's proof. In this case, 80,000 women with a safe delivery and 30,000 with treatment for STIs. That's the end.
Thanks very much, Stuart.